Hello, good afternoon, Dr. Wood and fellow committee members. My name is Carol Magruder, and I am the co-chair of the African American Tobacco Control Leadership Council. We are a member of the Save Lives Coalition, and we are here to support the California Healthcare Research and Prevention Tobacco Act of 2016. As you know, this act will increase the package of a package of cigarettes by $2, but it will more importantly increase the cheap tobacco products marketed to low-income African American, and Latino communities across this state. The AATCLC is a California-based collective of African American tobacco control advocates with a collective 200 years of experience in public health policy. We are researchers, academicians, activists. We are community members, mothers, fathers, sons, and daughters. Most of us have been personally touched by what statisticians refer to as lost years of life, lost years of productivity. These terms are used to quantify the death and disease attributable to the rampant tobacco use in our communities. I myself lost my beloved Aunt Barbara Lois Oldham, a resident of Los Angeles who died at the age of 58 from emphysema about 20 years ago. AATCL member Dr. Valerie Yerger, a researcher with the University of California, San Francisco, lost her mother, Bobbiette Walker, who at age 73 died from pulmonary and respiratory disease due to smoking. Bobby, as she was called, was smoke-free from November 1994 until sometime in 2009 when she relapsed and started smoking again. She, as well as my aunt, were closet smokers at the end of their lives, their addiction compounded with shame. They didn't know that that shame rested squarely with the tobacco industry that perniciously targeted and addicted them to cigarettes when they were teenagers. That shame now rests with us if we fail to enact legislation and public policies that protect our young people from a lifetime of addiction. It rests with us if we fail to provide cessation services to help people quit and stay quit. Our council has diligently been working to save the 45,000 black lives lost each year in this country from tobacco-related illnesses. We were formed in 2008 and have been at the forefront of the national debate on banning the sale of mentholated and other flavored tobacco products. I have here in my notes the statistics that I will recite, statistics about the enormous costs that all Californians, the vast majority of whom are non-smokers, pay to subsidize, or in the case of poor smokers, pay in full the health and societal cost of smoking. These numbers don't, and in fact can never capture the true human toll. Statisticians can never quantify the loss of a black grandmother. They don't know, they never could know the importance and the role of the black grandmother dead at 60 from lung cancer, her importance and stature to her family increasing in inverse proportion to her often negative net worth. As November approaches, it is this low-income black smoker that the tobacco industry will try to protect through the use of their front groups as they claim that tobacco taxes are unfair and aggressive to low-income smokers. They will argue that the price of this deadly addictive product should be kept low and affordable for them. It is true, low-income smokers and young people are price-sensitive, meaning they quit smoking or perhaps never start when cigarette prices are raised high, and we believe that is a good thing. I can assure this committee that no group cares more about low-income and poor smokers than we do. It has been our life work to defend and protect them from the predatory attacks of the tobacco industry. It has been our life work to defend them from the indifference and inequitable application of public health policy. With the historic passage of Prop 99 in 1988, California became the beacon not just for the rest of our country, but the whole world, as we showed them what could be done with good, comprehensive tobacco control policies. We have made tremendous gains, coming in behind Utah with our smoking prevalence now at 12% or less. But that 12% doesn't include African Americans, whose prevalence is 21%. And among low-income African Americans, this rate is 29%, the highest rate of any large ethnic group in this state. That 12% doesn't include American Indians, nor does it include the LGBT community with a smoking prevalence of between 25 and 35%. All boats did not rise with the high tide of California's public health victories. Lung cancer remains the leading cause of cancer death among Hispanic men and the second leading cause among Hispanic women. This Tobacco Prevention Tax Act has been carefully crafted. It has layer after layer of safeguards to protect taxpayers, ensure research money stays in the state, and it does not create any new agencies or government bodies. It strictly limits administrative spending to no more than 5% of the revenue generated, and it also requires biennial audits. But for us, this initiative also explicitly has provisions that address health inequity. Tobacco consumption is one of the main drivers of health inequities. Minimally 15% of the revenue generated for tobacco prevention and cessation will be focused on addressing and eliminating health disparities. This is critical because though priority populations bear the brunt of the insidious and predatory targeting of the tobacco industry, we have no foundations or voluntary organizations whose sole purpose is to defend us from the tobacco industry. Our leadership, advocacy, and capacity building efforts are in most part funded through revenue generated from tobacco taxes. Our communities have suffered as tobacco tax revenues have declined year after year. While the new bill signed by Governor Brown have made enormous and historic strides, we need to continue these efforts by increasing our tobacco tax to restore California's once stellar tobacco control program, and we need to build health equity so that all Californians can equally benefit. Thank you.
Thank you very much. Questions?